Hello, everybody. Good afternoon. I'm Vijayalakshmi Bhatia from Endocrinology Department. I'm a pediatric endocrinologist, but I'll try to do justice to adult diabetes and adult metabolic syndrome also. And I will cover diabetes and insulin therapy, as well as after that metabolic syndrome and diet for weight loss and hyperlipidemia all together rather than splitting it up. And Dr. Ved Prakash Maurya will take up the nutrition aspects of surgical patients after I'm finished. So I thought that I would take the opportunity, since all of you are working in this hospital where each and every ward has diabetic patients. Some are on oral hypoglycemic agent, some are on insulin. And diet, we cannot think of diet or nutrition therapy without thinking of the medications of diabetes. So I thought I'll take the opportunity to talk a little bit about insulin and its action. Because most of the patients, even when they're coming for surgery, are actually converted onto insulin. Sometimes they are left on oral hypoglycemic. So I will spend a bit of time talking about insulin. And I thought many of you might have heard about something called artificial pancreas, insulin pump. You might have heard of continuous glucose monitoring. So these are new terminologies, and I thought some of you might be interested to know what this is actually. So I will also take up the journey of discovery of insulin right up to artificial pancreas, and in between talk about pumps and CGMS. So going ahead, this is the timetable of relevant to diabetes and insulin. It was 1869 when a medical student called Paul Langerhans discovered the islets of Langerhans, and that they make insulin. And about 50 years later, the insulin was actually used on an experimental basis for the treatment of diabetes. And the researchers, Dr. MacLeod and Dr. Banting, got the Nobel Prize for this. They tied up with industry, and that is how this became actually available to everybody in the world through Eli Lilly company. Um, this insulin was the actual insulin present in animals. It was actually um, uh, isolated from the pancreas and the islets of cows and pigs. So we had bovine insulin and porcine insulin. And in those days, in the days of MacLeod and Banting and Best, they used to give this extract many, many times a day. As many times a day as the patient ate, they used to take a little shot of insulin, because this was what we know now as regular insulin. It used to act for a few hours. Then they realized that even if you don't eat, you need some basal insulin, even all through the night. And how to do this? Patient is not going to keep on waking up and taking small shots of insulin all day long. So in the laboratory, they converted this regular insulin by adding some protein and some kind of pH change, and they made NPH insulin from this regular insulin. So the NPH insulin has a long duration of action of about 8 to 12 hours, whereas regular insulin has a duration of about 6 hours. So that one could give one could take an injection of NPH along with the regular. The regular would take care of the meal-related glycemia, and the NPH would take care of the basal needs of the body. So one could inject NPH at night and be sure that it took care of glycemia throughout the night. So this was also a landmark in its own way. It allowed the patient to take less number of injections. Then came another Nobel Prize. It was insulin, which was the first molecule which was actually sequenced by genetic sequencing. And what we all know now as Sanger sequencing, it was insulin which was the first molecule to be sequenced. Because of this, synthetic insulin could be made. So in 1982, synthetic insulin of the same type, the same amino acid composition as our human insulin. So this synthetic insulin in those days, this was the year when I started doing my MD, and it was called monocomponent insulin. Extremely costly as compared to the bovine and porcine insulin. We used to get both bovine and porcine insulin in India. Later on, these have all got phased out. Meanwhile, in 1966 already, in USA, a pancreas transplantation, whole organ transplantation had already taken place. Later on, islet transplantations also took place. The big landmark, of course, everybody knows that the big landmark is the discovery and manufacture of insulin. But the second big landmark, which is responsible for prolonging the life as well as complication-free life of a diabetic patient, became home blood glucose monitoring. So in the days when I was doing my MD, a small glucometer was kept locked in the cupboard of my professor. And if there was an extremely sick patient, we used to beg him to open his cupboard and give us that. And then by the time we would find that the strips which were with it were already expired, etc. Now, these meters lie all around the place. They are free. The patient almost just gets a free meter almost and has to pay just for the strips. And even the strips are far cheaper than they used to be. So this is a second big landmark to make the life of a diabetic patient easy. Meanwhile, scientists tweaked the amino acid composition of regular insulin. They changed one amino acid, a second amino acid, just that much, just one or two amino acids, and changed the 3D structure of the insulin molecule, and changed, therefore, its pharmacokinetics. And I will tell about it. These are called analog or designer insulins. So human insulin and analog insulins. Meanwhile, a few years before that, the company Medtronic, which is a very big name in insulin pumps, made an insulin pump, made actually a nice small insulin pump, which could be commercially used. I will show you in the next slide what the first insulin pumps looked like and what they look like now. And I'll tell what is the meaning of pump in the next slide. A couple of years before that, continuous glucose monitoring systems, which are used in our hospital and in our by our patients' families now, they were first came in 1990. Then in 2013, in the University of Cambridge, the scientists made an algorithm, a mathematical algorithm software, to pair the blood glucose readings which came out from the continuous glucose monitoring system to the pump. So the CGMS told the pump, at this moment, my patient's blood glucose level is this much. And the pump used its own brain to deliver a certain amount of insulin. So this is just like our pancreas. Our pancreas senses the ambient glucose and puts out a certain amount of insulin. So this is called the artificial pancreas, where the CGMS and the pump are paired together. Let us not forget that in the middle of all this is our newly diagnosed patient who is angry, depressed, rebellious, bargaining, and then finally accepting the diagnosis and coming to a phase where she or he is accepting the education which we want to give and all the instructions. This is a all-pervasive kind of thought which has to be with us, whether it's a child or an adult. Why is diabetes so important to all of us? Patients are admitted in all your wards. We all know that for type 2 diabetes, diabetes is India is the diabetes capital of the world. But did we know that India is also the diabetes capital of the world for children? This has been a more recent realization. It has not been a recent happening, but it has been a recent realization. Because of our large childhood population, we have the second largest population of children with type 1 diabetes living in any one single country. And if we take children and adolescents, it is the largest, not even the second largest. So it's really our duty to equip ourselves well with the knowledge to support these children and adults. So let us talk about insulin now for the next few slides. Because to understand nutrition, we have to understand insulin. To understand insulin therapy, we have to understand nutrition. The two go hand in hand. So these are the three major meals of the day: breakfast, lunch, and dinner. And the conventional way of giving insulin is to give regular insulin, which is the red one, and NPH insulin, which I told you has a duration of 8 to 12 hours. One shot of these two things mixed together in the same syringe in the morning, half an hour before breakfast, and a second shot at dinner time. This is called split mixed conventional insulin regimen. However, we can see here that there are some problems. Out here in the mid-morning and in the mid-evening, in the mid-morning, there is no food. There is lots of regular and NPH roaming around in our blood. In the mid-afternoon, there is NPH in our blood. In the night, there is NPH in our blood. At these 3 times, there is no food. So how do we deal with this? We dealt with it. We thought we were very smart and we said, let us mandate a snack at mid-morning and a snack in the afternoon to get rid of those hypos. We could do that. But in the night, we will not ask the patient to get up in the middle of the night. We do ask them have a bedtime snack, but then not in the middle of the night. This kind of, so just giving regular and NPH in the morning and night is not good enough. We want to give regular and NPH in the morning, regular and NPH at night, and a regular in the afternoon to take care of the lunchtime sugars. So this is we all in India call it modified basal bolus regimen. This is the cheapest way of giving a nearly physiological method of giving insulin, and this is actually the kind of the backbone of our diabetes management with insulin. Still, we can see that a little bit of highs are left here. A little bit of this snack is unattended. A little bit of this snack is unattended. And so we can give a little bit of regular or analog, and I'll tell you in the next slide why analog, little bit of regular or analog here to take care of this, and a little bit here also to take care of the evening snack. So actually, in the adolescent age group, many of our children actually take regular and NPH in the morning, regular and NPH at night, regular at lunchtime, and another small regular at evening snack also. Actually, if we start, treating them, doing their regimen right from the beginning as if this is the only way of giving insulin, they don't know that there was any other way. And so they accept it much better than if we pounce it on them later. But taking an insulin at school is a big, big difficulty. Most of the children, no matter how intelligent and compliant and good the families are, it is a big social problem for them to take insulin at school because of the very poor awareness in society. But still, in spite of all this, we are not able to take care of the night lows because of this NPH. To deal with that, another kind of designer insulin is peakless. You can see that this profile, this is glargine, absolutely flat. It doesn't have these peaks which are there, or even this low peak which is there with NPH. So this provides a basal insulin which does not have peaks, and therefore the person is much less prone to hypoglycemia. It's called peakless insulin. So it takes the place of the 2 NPHs. We can give this glargine once a day. Sometimes we may need to give it twice a day. So it removes, we need not give the NPH. It takes care of the night hypos. So again, if cost is not a problem, which is a problem with glargine, it's a bit costlier than NPH. Otherwise, this is the ideal way how we would be giving insulin. And we do also give insulin to all our insulin-dependent diabetic patients. For non-insulin dependent also, after a few years of oral hypoglycemic agents, their capacity to secrete enough insulin for the amount of insulin resistance which is there in the body is diminished. Their capacity to secrete the insulin is diminished, and they need some insulin. They don't manage with just oral hypoglycemic agents. For them also, this detimer is a very useful, detimer or glargine, this peakless insulin is a very useful kind of insulin. It can be combined with OHAs for some years, that is oral hypoglycemic agents like metformin, etc. But after some years, they may also need meal-related insulin in addition to the basal insulin. Now coming, this is just, I told you that I will be telling you a little bit more about the analogs. So this is regular and NPH. This is the profile. The regular peaks at about 2 hours and it lasts for about 6 hours. The NPH also has a small peak at about 4-5 hours and it lasts for about 8 to 10 hours. In contrast to that, look at this Aspart or Lispro. These are the analog insulins where 1 or 2 amino acids are different from the human regular insulin. And it has a very sharp, tall, action to mirror the carbohydrates and calories released from the blood glucose released from the carbohydrates in a particular meal. And it goes away also fast. Its duration of action is only 4 hours. So as I showed you in the previous slide, the unwanted lows which are there between the meals are minimized by giving aspart or lispro. These are called rapid acting insulins instead of the regular. So, and the other kind of analog is glargine or the peakless insulin, which I already told you about in the previous slide. I want to tell you that since regular insulin is given 30 minutes before a meal, and rapid acting insulin in contrast is given 15 minutes before the meal, it is a very useful item. This rapid acting insulin is a very useful thing for using for meal related insulin for toddlers, where the mothers can hardly ever judge whether the child is actually going to eat or not. So many times mom has given the insulin half an hour before, if it's regular insulin, and then she finds that the child is not ready to eat at all and then is really worried about a hypo. So to attend to that issue, we often say that until your child is yet another 1 or 2 years older, until that time you can give rapid acting insulin, so that you can give it either 15 minutes before or just immediately before the meal. Or sometimes you can give half the dose immediately before and half the dose just during the middle of the meal once the child is eating reliably. Glargine and NPH are not very tightly linked to the meal timing. It can be given irrespective of the meal timing, but as I said, NPH does have a bit of peak, so we do tell people when to take the NPH. I want to say that many of you are very familiar with Mixtard. This is pre-mixed in a fixed ratio of 30-70 or 50-50 of regular and NPH insulin. So since the blood sugars fluctuate very much in type 1 diabetes, pre-mixed insulin is not a good insulin for type 1 diabetes child or adult. But it can do pretty well for type 2 diabetes because the blood sugars don't fluctuate very much from one day to the next. So if we fix a certain ratio, that ratio is likely to stay good for many years. Here also, if the NPH is substituted by the peakless insulin glargine or detima, it reduces hypoglycemia and is really worth the expenditure for the patient. These are insulin pens. They take the place of the vial and syringe. They are less threatening, easy to carry, convenient. And for people who have impaired vision, you can just dial. So you can dial 1, 2, 3. You can hear the clicks and you can dial how many units of insulin you want. So it's easier to use than a syringe. But it comes at a bit of cost. It is very non-threatening for children. So it's also a very good thing for the parents of little children to use a pen rather than the vial and syringe. But it comes a little higher cost. The regular insulin in a vial costs 30 paisa per unit. In contrast, these are all in our HRF. The actual rates outside are even more than this. But the regular insulin in a cartridge for the pen costs a quarter more. And the analog insulins, Lispro, Aspart, Glargine, they cost about 5 times the cost of the simple regular and NPH insulin. So when we have some patients from underprivileged family, we don't try to use analog insulins. What are pumps? A pump, as the name indicates, now the pump has become so small, just like our SGPGI mobile. It delivers, it pumps out regular insulin only. We don't have to use any NPH or glargine. It pumps out the regular insulin all through the 24 hours at a certain basal rate. And I will tell you in the next slide how we can set different basal rates for different times. Like in the night, to prevent hypoglycemia, we can set a little lower basal rate. In the early morning hours when cortisol, growth hormone and all are high, these are counter-regulatory hormones which cause the dawn phenomenon of high glucose in the early morning hours. We can set already, preset the rate or the pump rate to deliver higher basal insulin rate for 3-4 hours during the early dawn time. So it's extremely convenient to get very good blood sugar control. Also, this is the cannula through which the insulin goes. It is put into the subcutaneous tissue, just like the insulin syringe or pen. But this cannula is changed only once in 3 days. So for toddlers, it is very non-threatening. Instead of taking 3 or 5 injections a day, this is 1 injection once in 3 days. So the number of pricks is less. It's also a very good thing for children. Of course, all this convenience comes at a cost. The cost roughly is about 5,000 rupees per month extra than whatever they would spend for the insulin and testing. What is CGMS? Continuous Glucose Monitoring System. Here, a sensor is inserted in the subcutaneous tissue, and it is kept there for 3 to 5 to 14 days. The one which we have, which is less expensive and is available nowadays in our HRF, is sometimes called FGMS, Flash Glucose Monitoring System. Don't worry about that. That we can use for 14 days. Once we insert it, we can use it for 14 days. This one inserted in the abdomen is by Medtronic company, and the one by Abbott, which we use in our HRF, which is cheaper, is inserted behind the upper arm. So what does this do? This picks up the tissue fluid glucose. It doesn't go inside the blood. It measures the glucose in the tissue fluid. And we can calibrate this, or it comes factory calibrated also, that if this much is the tissue fluid glucose, this much must be the blood glucose. So when it shows the reading, it actually shows the reading as if we are reading blood glucose, but it actually doesn't measure it in the blood, it measures it in the tissue fluid. And the blood glucose of right now takes 5 to 15 minutes to seep out into our subcutaneous tissue. And therefore, glucose value which we read right now actually reflects the blood glucose which was there 5 to 15 minutes back. 15 minutes in the FGMS system and 5 minutes in the Medtronic CGMS system. So you can imagine that with this sensor, which is put once in 14 days, but you can avoid multiple pricks, finger pricks each day, and you can actually just flash this thing, this receiver. It also is the size of our hospital mobile, tiny little thing like a pager. And you can just flash it over the skin, flash means just show it like that over the skin, and you can get a reading. So it's a marvelous thing, really marvelous. The only thing is that at blood sugar values less than 70, in the hypoglycemic range, it's not highly accurate. So if the caregiver finds that the values are more than 80 to 100 and up to about 200, they are safe, they're happy. They don't have to wake the patient up and do a finger prick and measure the blood glucose. And I will show you some records later in the next slide. It keeps recording for the whole 24 hours. So we can retrospectively also take out a pattern and discuss it with the healthcare provider. So here are 4 finger prick blood sugar readings. This band is within the normal range, 70 to 140 is what is set here. So here, these 4 readings which the patient has taken on one day, 2 readings are close to 70, 2 readings, and one is absolutely in the middle, and one is a little above 140. But the CGMS shows that in the whole 24 hours, here were those 4 readings, 1, 2, 3, 4. But look at the actual blood sugar readings, how much they fluctuated and for how many hours the patient had high blood sugar readings. So this is the benefit, and another benefit of the CGMS log. A retrospective look at the pattern and discussion with the healthcare provider so that the doses and diet, etc., can be tweaked. This is from one of our own patients. We were able to show this to mom, that because she was afraid of hypoglycemia and she was deliberately giving less insulin before breakfast, before sending the child to school, giving a huge breakfast, a huge tiffin, uncovered by insulin. The child was having for like 6 hours each day, was having high sugars, really high. This is like 300 to 400 sugars. And she never knew this because children don't test in the school. So she used to think that the child is fine because this is where she used to test. This is at home. This is at home. And these sugars were very good. And she used to say, Pata nahi kyun A1C itna uncha aata hai. So we were able to show her this. And we were also able to show her that this whole night for 8 hours, the child was in hypoglycemia. And this second night, for half the night, he was in hypoglycemia. So this is a very useful tool. It costs 2,000 rupees for 15 days. Now, if the CGMS could talk to the pump and tell the pump that at this minute, this is the blood sugar, then the pump could actually put out the correct amount of insulin for that blood sugar at that time. And this is what is there in the artificial pancreas. They have to talk to each other. If you wear the pump and you don't wear the CGMS, this won't work. This was how the first pump looked many, many decades ago. A big thing strapped on a backpack to the patient, or before this, it was even bigger than this. Actually, it was only by the bedside. The person couldn't wear it and walk around. And now they have become so small and handy. So we get pumps in India, which if you wear it with the CGMS, it has a low glucose suspend. This is okay. The CGMS tells the pump that now my sugar is showing 60. So the pump will stop delivering insulin and deliver an alarm to the patient to take action. Then there is a pump with a predictive low glucose suspend. The pump will the CGMS will understand that, oh, my sugar is falling very fast from 110 to 80. And if I don't tell this to the pump, in the next few minutes, my patient will go into hypoglycemia. So let me warn the pump already. So this is a predictive low glucose suspend, even better than the low glucose suspend. So before the hypoglycemia actually happens, the pump stops and delivers an alarm. And the ultimate conversation between the CGMS and the pump results in the artificial pancreas, which I will show you in the next slide. The pump and the CGMS have to be used concomitantly. By the way, the artificial pancreas, which is nothing but a pump which is talking to the CGMS, is actually in commercial use for the last 1 to 2 years or so in other countries. And some of your patients who are very well off may actually buy one in another country and bring it here. So you all should know a little bit. The pump puts out a basal rate tailored to the blood glucose value picked up by the CGMS, just like our natural pancreas would do. All this is enabled by a software algorithm teaching the pump that if the blood glucose is falling or rising at so-and-so rate, you must put out this much insulin to dampen the rise or fall. So this is the philosophy of the artificial pancreas. In today's technology, the artificial pancreas cannot take care of meal boluses. The human mind has to intervene and calculate the carbohydrates in the meal and click the amount of insulin which has to be delivered as a bolus. But the basal can be very well taken care of by the pump. Okay, now we come to diet. This was my mandate, but I took Anita's permission to actually talk about insulin for some time. The diet for diabetes is actually a balanced diet, which is good for any child or any adult, except we have to avoid excess of simple sugars. But in today's day and age, avoiding excess of simple sugars is good for everybody, leave alone diabetic patient. The quantity of carbohydrate mainly decides the blood glucose fluctuation in the immediate 4 hours after the meal. So we must remember that. We do teach our patients a lot about carbohydrates. I will talk a little bit about what is glycemic index and carbohydrate counting. For a child, we must make allowance for festivals and birthdays and treats, and as little of this as possible for adults, because adults have to lose weight. Most of them with type 2 diabetes are overweight. So in overweight, we are trying to lose weight. We have no scope for treats actually. Our food is composed of the macronutrients. I don't need to tell this audience too much, but we'll talk first about protein, then about fat, then about carbohydrates. And protein can have just pure protein. It can have protein plus carbohydrate and fat, like in milk product. It can have protein and fat, like in most of the non-vegetarian products. And it can have protein and carbohydrate, which is all our dals. Fats. We know about fats, but there are fats and other fats. So these are unsaturated. mono-unsaturated and poly-unsaturated. And a mixture of mono and poly-unsaturated is healthy for us. Saturated fats, which only come from animal products, are not good for us. And trans fats are also not good for our cardiovascular risk. These come from refried oil as well as from margarine or vanaspati ghee, as in the bakery products. Coming to carbohydrates, carbohydrates can be complex and simple carbohydrates. As we all know, simple carbohydrates are not very good for us. In addition to raising the blood sugar fast, if we are non-diabetic also, they are very energy dense. So we have to try to avoid simple carbohydrates and try to have as much of complex carbohydrates as possible. If we have any meal with zero carbohydrates and we take the same amount of insulin, we may land up in hypoglycemia. So we should be very careful. Many of you are surgical students, surgical patients, NPO for tomorrow morning's OT. Somebody silently is taking care of all these things, as the patient should not be NPO and get their usual doses. All these things are being taken care of. Coming to what is glycemic index. Let me read out. Glycemic index is a value used to measure how fast and how prolonged the blood glucose levels rise in response to that food being eaten. So if glucose and sucrose are taken as 100, in comparison to that, other foods are rated. So those foods which are near to 100, say 80, 90 or 100, they are high glycemic index. Those which are about in the 50s and low 60s, they are medium glycemic index. And those which are less than 50 are low glycemic index foods. They raise the blood sugar slowly. And it is favorable for us to eat low glycemic index carbohydrates. So these are low glycemic index foods. We are lucky we live in North India, and the roti, even a simple atte ki roti, and certainly misi roti, which has jaw, which is barley, and besan, that kind of a flour is actually the lowest possible, almost the lowest possible glycemic index food which we can have. And chana, like Kabuli chana, Bengal gram, these are all very low, very, very low glycemic index foods. All dals, chilke wali dals and other dals are also very low glycemic index foods. And of course, fruit and vegetables, which have a lot of fiber, are low glycemic index foods. I will show you some fruit which are high glycemic index. Watermelon, chiku, and very ripe banana. These are high glycemic index. Dates, then all things made out of jaggery, honey, etc. They are high glycemic index. We must remember that fiber and fat, they slow the blood glucose rise. So we teach our patients that if they are having a hypo, there's no use eating a chocolate, like a milk chocolate or ice cream. Their hypo will not be remedied very fast because the blood sugar will rise slowly, the glucose will rise slowly in response to the sugar because there's a fat component. Carbohydrate counting, only one slide I'm putting. We do teach our patients that on a certain day, if you don't want to eat your 2 rotis, you can exchange it with this much amount of rice, or you can have 1 roti and exchange 1 roti with this much amount of rice or this much amount of bread, so that your total amount of carbohydrate remains the same, tailored to the amount of insulin which you are usually taking, and yet you can enjoy the variety of food. Carbohydrate forms about 55 to 65% of our calories. And so, and it, as I already said, it determines the blood sugar rise in the immediate 3 to 4 hours after the meal. So teaching them a lot about carbohydrate and carbohydrate counting and carbohydrate content of various foods is very fruitful, is extremely important. So here, for example, there is a breakfast where normally the person is taking 2 slices of bread, and on one day he wants to take roti instead. So then she takes 2 rotis. But she says, I'm not hungry for more. But then she understands by our teaching that that gives her Okay. It gives her the 30 grams of carbohydrates, just as the two large slices of bread. She was eating egg white with that bread, but today she doesn't want to eat egg white with the roti. She wants to eat paneer. So we have taught her how much paneer to take, which is the protein equivalent of the egg white. And so, um, what is missing? Maybe the jam. So there is no jam. Some carbohydrate would have come from the jam. And so some carbohydrate is getting made up from the milk. Some protein and some carbohydrate is getting made up from the milk, so that the total grams of carbohydrate is remaining the same. As I already said, the proportion of macronutrients in a diet suitable for diabetes is about 55 to 65% carbohydrates. I can tell you that the kind of food which is served in our kitchen, for example, is at least 65% carbohydrates, and it's a big struggle to actually keep up the amount of protein and fat in the food which is served in the kitchen. It's very high in carbohydrate. What we cook at home, if it is a vegetarian diet, I think that it may be having a bit more fat. And of course, those who are conscious about it and having enough of dal and milk products, I think would be having a diet more like 60% carbohydrates, 20 or 15 to 20% protein, and about 25% fat. If we have too much carbohydrate, too high a carbohydrate diet, it will result in a high triglyceride. So this is not good for our metabolic syndrome risk. I won't talk about free foods. These are foods which have nil or very little calories and can be used at the time when somebody is hungry and has already eaten their permissible amount of food suitable for them. So then they can use these in liberal quantities, especially if they want to lose weight. Sugar substitutes are not a no-no. In moderate quantities, they can be used, and they do help people for losing weight particularly. Now we'll switch gears and come to metabolic syndrome. But I just want to allow you all to take a breather and ask if any of you have any comments or questions. Some of you are from the medical departments, I saw. If any of you wants to add or subtract from what I told, please unmute.
Hello, ma'am. I'm Dr. Pankti from Immunology.
Yes.
I had a question about CGMS. You said the sensor has to be inserted every 15 days.
Yeah, 14.
Okay, so is that a surgical thing or?
No, it's really cute. We do it all the time in our outpatient. Any day we can show you, or we can take a video clip and actually pass it on to some of you who want. It is, what equivalent shall I say? So it has an applicator, and it's a round coin size. That sensor is the size of a coin, a 10 rupee coin, and it has a small filament of less than a centimeter, maybe half a centimeter, poking out from the center of that filament is what has to go in the subcutaneous tissue. So we place that an applicator with that sensor and its filament pointing towards the skin side of things, and the upper side. You know how we do a blood glucose pricker? We have a pricker and the lancet jumps out from it and pricks
Yes, ma'am.
the thing. Just like that, the sensor and the filament is actually hidden inside the applicator. And we place that applicator, first we clean the back of the arm, and then we place the applicator over it, and we just press it the way we press the pricker for the blood glucose. And the sensor, that is the 10 rupee coin thing, and the filament, it jumps out and enters the skin, and it has a very strong glue. It sticks to the skin. Then very gently we pull out the applicator, and that sensor stays there. It's very nice. It's really painless. Nobody worries about, no child or adult has ever complained about the pain. And mostly it sticks very nicely. This particular Abbott one sticks very nicely. Sometimes it may stop reading or come off after 10 days or 14 days, but most of the time it's pretty good. I wouldn't say that that it's 100% accurate. in the low readings, like less than 70 or so, it is not very accurate. If our sensor is showing that, we should do a finger prick immediately. And if our blood sugar is changing very fast, rising very fast or falling very fast, it is also not very accurate. So we tell our patients, don't stop doing finger pricks. And sometimes there is a batch to batch variation in the accuracy. Some batches are very good, some batches are not so good. But altogether, I would say it is a boon for the caregivers and the patients. Yes.
Okay, thank you, ma'am.
Ma'am, I wanted to know whether xylitol and aspartame can we prescribe them to our patients. I mean, are they medically approved for prescription? Because they are known to have side effects like diarrhea because they disturb the gut bacteria, and in long-term effect, they are also known to affect the kidney. So, can we prescribe them to our patients, even if they are not that?
Aspartame
Because
and the other sweeteners,
stevia
you're
and
talking about
xylitol,
the
both,
sweeteners,
ma'am.
yeah. No, it is not true that they damage the kidney. So the only condition which is a absolute contraindication for these is phenylketonuria. And otherwise, in moderate amounts, even actually every year we check the statement put out by the American Diabetes Association and other associations, UK Diabetes and so many others, International Diabetes Federation, and also we read the literature. So I can say that as of this year, there is no such, and these have been in use for the last at least 50 to 60 years. So as of now, there is no such worry about adverse effects from these.
Okay, thank you, ma'am.
But I would say that we should always teach our patients to take it in moderate amounts.
Okay, ma'am.
Yeah.
Thank you, ma'am.
Okay, so we can go ahead now to metabolic syndrome. This is not a syndrome, unlike the syndromes which we are familiar with, but it is actually a collection of risk factors which predict future diabetes, future heart disease, that is coronary heart disease, and future stroke. And all of these have a common denominator, and that is insulin resistance and inflammation. So so this is actually a combination of risk factors. If we recognize these to be present in a person who is in front of us, we should take greater efforts to modify and mitigate those factors which that patient has. And there are very good data to say that if we try to mitigate those factors, it does result in diminution of these outcomes. And these are actually very frightening outcomes. I will show you how much prevalence of all these things is there in our country. So we all, no matter, just like we were taught long ago that no matter in which branch of medicine we are, we have to take certain things seriously. It is, whether we are a radiologist or a surgeon or a medical person or anything like that, this is one of the things which all of us have to give a lot of importance in our lives, because actually it affects our own families and neighbors and friends. So the International Diabetes Federation gave the following definition for metabolic syndrome. And the American, this is called the National Cholesterol Education Program, I think, Adult Treatment Panel 3. Basically, this is a American definition. There are many other definitions too. They vary very slightly in some of these criteria. So coming to the International Diabetes Federation, they gave a lot of importance to the presence of not only obesity, but central obesity. And they defined it as a waist circumference, not just BMI. So the International Diabetes Federation said that if you have a high waist circumference, more than 94 centimeters in men and 80 centimeters in women, plus any two of the following four: an impaired fasting glucose. So just to remind some of you, the diabetes cutoff is 126, but there is an island of blood sugar between normal and diabetes, that is between 100 and 126. If your blood sugar is there, or if your triglycerides are more than 150, if the HDL cholesterol is low, less than 40 in men and 50 in women, or if the blood pressure is more than 130 systolic or more than 85 diastolic. So 2 out of these 4 plus the mandatory definition of central obesity, then we have metabolic syndrome, and we should watch out for our future risk of diabetes, heart disease, and stroke. According to the NCEP 83 criteria, they give equal weightage to this obesity, not a special weightage. So they say any 3 of the below 5. Otherwise, these other 4 criteria are the same. Their waist circumference criteria are different. This is the Western criteria. International Diabetes Federation has tweaked the waist circumference to suit majority of the populations in the world, because in the Eastern Oriental ethnicity, you need to have a less waist circumference to be at risk for metabolic syndrome. This is a graph which really shows us what is the trouble we Indians have. This is the BMI on the x-axis and prevalence of diabetes A in men, B in women on the y-axis. And we can see that for every level of BMI, let us take 25 here, which is the definition cutoff for obesity in some of our definitions for us Indians. The diabetes prevalence is much higher, both for men and for women, than the Europeans. And other races are in between. This is the Japanese, this is the Chinese, and one is the Maltese. So Indians are way up there. At every level of BMI, we have a higher prevalence of diabetes. It is really frightening. And I will show you some prevalences also, which are frightening. Since we have give so much importance to waist circumference, and why? Because for every level of BMI, why do we have this? It is not only BMI or general obesity, which is predictive of diabetes, but a central obesity. And central obesity is measured by waist or waist-hip ratio. Actually, people say that there is no need to waste time and do a waist-hip ratio. You can just do the waist circumference. That's more than enough. And that is why in those definitions, you saw waist circumference. The waist circumference is measured just above the anterior superior iliac spine. This is acanthosis. This is the velvety dark skin appearance of skin. On this person, it is on the back and side of her neck. This is called acanthosis, and this also shows us that there is insulin resistance in that person and gives a future risk of diabetes. It is very helpful for us to educate the patient. See, this thing is there, this person is having it, she is overweight, and this gives an additional risk of diabetes. Here are the data which I was talking about. This is a published study from our department in one of the affluent neighborhoods of Lucknow. We went for many months, many people of our department went for many months, led by Dr. Subhash Yadav, and found that the overall adult population from the age group of 30 to above 70 had a prevalence of diabetes, not just impaired glucose tolerance, but diabetes of nearly 30%. Nearly 30% of that neighborhood had diabetes in their adult age. And this approached about 40% in the 60s and 70s. This is really striking data. It got a lot of attention actually nationally and internationally. This is worse still, the prevalence of hypertension. In the same neighborhood, 60% of that population in the age group of 60s and 70s, and even in the age group of 30s, a good 18 to 20% in the 30s and 40s were already suffering from hypertension. Overweight, equally bad. And these are the risk factors for metabolic syndrome. So actually this in India and in developing countries like India, still till now, the affluent people are the ones who are more overweight and more susceptible to all these things. But in developed countries, many years ago, it was the same, but now it is the lower socioeconomic strata who are more showing these parameters. And India is somewhere in the middle. We are a society in transition, and our lower middle income families are the ones actually suffering. They are the ones who can least afford it, and they are the ones who are suffering from these problems. Physical activity category. 80% of the people were only sedentary or light, and we are supposed to be having moderate physical activity. What is the evidence that lifestyle changes do work? They do. They decrease the progression of impaired glucose tolerance to diabetes. They improve glycemic control. They decrease cardiovascular events. And the next few slides, I don't need you to pour through the slides very carefully, but there are national in India, this is from Chennai, and international data from Oriental as well as Western nations, which show reduced conversion of impaired glucose tolerance. Impaired glucose tolerance includes fasting between 100 and 125, or post-glucose between 140 and 200. Overt diabetes is more than 200. So reduced conversion of impaired glucose tolerance to diabetes has been achieved with lifestyle measures. Also, reduction in cardiovascular disease has been achieved by lifestyle measures, by weight loss, exercise, and a healthy diet in many studies. And I've just put up a couple of studies here. So the guidelines for patients who are at risk, who meet positive criteria for metabolic syndrome, they are 4. Number 1, weight loss. Number 2, healthy diet irrespective of weight loss, so that the hyperlipidemia is prevented or dealt with. Exercise and cessation of smoking and diminution of alcohol intake. We'll look at each of these one by one. Weight loss. If we have a mild amount of overweight, we can go with half to 1 kg per month. But if we have a huge overweight, we should be telling half to 1 kg per week. Very low calorie diets like 600 calories, 800 calories are not recommended because they are not sustainable. Whether to choose low carbohydrate or low fat or a combination, etc., is controversial, and I'll show over the next slide to some data. And of course, regular exercise is extremely important to complement our efforts at the dietary therapy. This slide shows the participants were randomized to go into 4 kinds of diet. The first component is carbohydrate, the second is protein, and the third is fat. So you can see that the diets ranged from 65% carbohydrate, 20% fat, all the way to 35% carbohydrate, 40% fat, and also 55% carbohydrate, 20% fat, 25% protein. So all different combinations, 4 of them. And you can see that all of them achieved weight loss in the immediate 6 months. All of them regained some weight in the next 24 months. They were successful at not going right back to the initial at 24 months, but there was no statistical significant difference between the 4 types of diet. So basically, the more important message is to decrease the energy density by whatever means which can appeal to that particular patient. There are some dietary messages which are useful for everybody, irrespective of whether they need to lose weight or not. Limit the amount of saturated fat and trans fats. Use more of unsaturated and poly and mono unsaturated fats. Use fibers which come from fruit, vegetables, and legumes. And exchange rapidly absorbable, that is simple carbohydrates, with the complex carbohydrates. ICMR has added, this all comes from American Diabetes Association. ICMR has added avoid refined foods, roots, and tubers. The unifying principle of dietary patterns for tackling overweight is energy density. This is really an important concept. So we need strategies to increase the portion of low energy dense foods and decrease the proportion of high energy dense foods. There are lots of publications in the literature. Even 1 month won't be enough to review all of those as to various different kind of dietary strategies, what is successful and what is not. All are successful in the short term. Many are unsuccessful in the long term, and we need motivation and a lot of social science research and methods to actually keep up the adherence over the long term and resist temptations. So I'll just read out: substitute lower energy dense foods for higher energy dense food, decrease the energy density of the main course, add a low energy density first course like salad or a very liquidy soup, manage the type of fats, increase the amount of protein and fiber, consider non-nutritive sweeteners, to drink a lot of beverage to fill up our stomach, choose water and other low calorie beverage. Then methods to obtain cooperation and adherence. One is incorporate pre-proportioned foods uh, meal portioning tools. Like for example, there were some studies with a certain amount of liquid diet, like a shake, and you were allowed only those many bottles of that in the whole day, and they got fantastic weight loss. But none of these will necessarily stay in the long term. So in the long term, really one needs a lot of motivation and social psychology kind of inputs. This is a picture to show energy dense food. This food, all these 5 bowls have 100 calorie snack, but this one is highly energy dense. It has 4 calories per gram. And this one is the least energy dense. It has 0.18 calories per gram. These are tomatoes, a bowl full of tomatoes. These are apple slices. These are grapes. These are raisins, kishmish. And these are, they call it jelly beans. I guess we can call it like sweet candy. Again, this highlights a low energy dense satisfying meal. This is high energy dense. It is, here is a steak, here is a baked potato with sour cream dressing on it and a little bit of vegetable. This has to become into half the energy density, which is 400 calories. Now, if we make it 400 calories, here is a tiny amount of steak, a tiny amount of baked potato and no vegetables. Person is not going to be full at all. His stomach is going to still feel empty. But if we mix up a lot of vegetable portion and continue to have a reasonable amount of protein and baked potato and not use sour cream, but use some yogurt kind of dressing or a low fat dressing on the baked potato, we can still have a very satisfying but low energy dense meal. This is my second last slide, I think. This tells us, let us just concentrate on this one, a healthy US style eating pattern. This is healthy Mediterranean style eating pattern, slightly different. This is 1800 calories, this is 1400. So 1800 calories, what we should be having in an ideal diet all through the day in 124 hours. We should be having 2.5 cups of vegetables, 1.5 cups of fruit. This would be about 6 thin pulkas or the equivalent of that in the whole day. 3 cups of dairy, that means milk, yogurt, dahi, etc. 5 protein equivalents. Let us say this could be 1 egg white and 4, this 4 ounces would be 1 full cup full to 200 ml cup of cooked legume or paneer and 24 grams of oil. So I think if I compare it to what we may be having, we may be okay in these pulkas. In dairy, many people may not be having 3 cups of milk, actually milk or milk products per day. They should increase it. Certainly they will need to increase their fruit, which is a premium costly item. And certainly they could increase seasonal vegetables to 2.5 cups. Alcohol and tobacco. American Diabetes Association says decrease the number of drinks per day. ICMR says don't take any alcohol. If at all, consume only in moderation. Everybody says strictly avoid tobacco and smoking because it has multiple harmful effects, peripheral vascular disease also, in addition to everything else. This is about physical activity. Moderate physical activity, 30 to 40 minutes every day. These are examples of moderate physical activity. So this is brisk walking. It should be that we can go from the end of the type 4, the last type 4 house, to Mani Monta and back to the last type 4 house within half an hour. Not loitering around, we have to walk fast, or else we can jog. I'm very happy to see many of the students jogging in the evening. So moderate type of exercise, 5 to 7 days a week. Let us make it 7 instead of 5. If people are not used to exercise, they should gradually increase the duration and individualize the exercise program. If they have any previous heart disease, they should talk to their doctor first before starting on an exercise program. I won't talk too much about yoga. We often tell our kids for dancing because sometimes there is no place to play. So instead of doing cycling, dancing is very good. In summary, diet is the cornerstone of diabetes management. Insulin and medication should be tailored to the dietary pattern of the family. A diabetic diet is the same as an otherwise healthy diet for the whole family. To avoid future diabetes, cardiovascular risk, and stroke risk, we should pay attention to: number 1, maintenance of weight or losing weight to the ideal body weight; healthy eating irrespective of whether we want to lose weight; physical activity; quitting smoking; and minimizing alcohol. Lastly, nothing will work unless we provide tools to our patients for adherence. Thank you for your attention.